Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. And welcome to the 6th Emergency Medicine Seminar Series 2024. I'm Dr. Muhammad Azhar Ashari bin Abdul Karim, second year master student in Emergency Medicine and Hospital Chancellor Tuanku Mufris, UKM, and I'll be your moderator for this exciting event. We are honored to have you join us, whether you are here live or tuning in from different locations around the world via Zoom. This week marks the beginning of our seminar series, and we are kicking off with a theme that is highly relevant to emergency medicine, clinical toxicology. As we all know, toxicology plays a critical role in the emergency department, where rapid decision-making can be the difference between life and death, from accidental poisonings to intentional overdose and environmental toxins. The need for accurate, swift diagnosis and treatment is very essential. Today, we'll be hearing from some of the leading experts in the field who will share their invaluable knowledge and insights. Their experience in managing toxicological emergencies will provide us with tools and strategies to enhance our practice in emergency care. Before we begin, I would like to go over a few housekeeping rules. First, kindly post your questions in the Q&A session. Second, questions will be answered in the forum Q&A session. Third, feedback form will be available at the end of the webinar. Fourth, please fill in and submit the feedback form for the e-certificate and for the CPD point. Fifth, please ensure your mic are mute during the presentation to avoid background noise. Across the screen, we come to learn with eager minds and hearts that burn. Though we miles apart, we are side by side. Together in knowledge, we take a great pride. In every click, in every chat, we share ideas. Imagine that. The power of Zoom brings us near. Let's make each moment matter here. Our first topic for this webinar is one that holds critical importance in clinical toxicology, paracetamol toxicity. I'm honored to introduce our esteemed speakers, Dr. Jennifer and Rafael. Dr. Jennifer is a highly accomplished physician with a strong background in clinical and occupational toxicology. She is currently the head of Toxicology Specialty Center at the Ilocos Training and Regional Medical Center. Dr. Jennifer's extensive training includes a fellowship in clinical and occupational toxicology from the National Poison Management and Control Center at the University of Philippines. She has also attended numerous specialized training programs on hazardous material response, toxicology risk assessment, and environmental health, which makes her an expert on today's topic. With her deep knowledge and vast experience, Dr. Jennifer will guide us on paracetamol toxicity from its clinical presentation to management strategies. Please join me in welcoming Dr. Jennifer and Rafael. Dr. Jennifer.
Thank you, Doctor. Okay, so good morning again, everyone. Today, I will be presenting the updates in paracetamol poisoning. So I have two objectives for this presentation. Firstly, to discuss the current trends and management status of paracetamol poisoning. And second, to discuss the new therapeutic strategies in the management of paracetamol poisoning. So this is the outline of my presentation. So paracetamol, as we all know, is known as acetaminophen in the Western countries. It's also known as APAP or N-acetyl para-aminophenol. And this is one of the most common oral analgesics and antipyretics available in the market. It acts through selective inhibition of cyclooxygenase in the central nervous system. This is one of the most common agents taken in deliberate self-poisoning and in accidental overdose among adults and children. In fact, based on the Philippine data from the National Poison Management and Control Center, paracetamol poisoning has been consistently within the top 3 agents for the past 5 years. And in the past 2 years, it has been number 1. In the United States, it is the second most common cause of severe acute liver injury, necessitating liver transplantation. So for the current management strategies, for patients who comes in at the ED or at the emergency room within an hour of ingestion, we do single dose activated charcoal with gastric lavage. And we give N-acetylcysteine, which is the antidote, within 4 to 24 hours from the time of ingestion for those patients who are at risk for hepatotoxicity. So the basis for risk assessment for hepatotoxicity is by plotting the serum acetaminophen level or the acetaminophen concentration in the Rumac-Matthew nomogram. However, we do individualized approach for patients who have modified or sustained release preparations ingestion. For patients who have massive APAP ingestion, which is defined as ingestion of at least more than 30 grams of paracetamol or 500 milligrams per kilo of paracetamol, or serum acetaminophen concentration of more than 300 micrograms per liter at 4 hours post-ingestion. We also do individualized approach for patients with repeated supratherapeutic ingestion and those patients who had overdose from intravenous paracetamol or liquid paracetamol preparations. And of course, we do individualized approach based on availability of resources in our institutions. So what's new in paracetamol poisoning management? Firstly, we have activated charcoal for massive paracetamol ingestion. So the standard dose of intravenous acetylcysteine is 300 milligrams per kilo, which is given over 20 to 21 hours, given as either a 2 or 3 bag infusion. Although this regimen is sufficient for the majority of overdoses, questions remain as to whether this regimen is optimal in patients with high paracetamol concentrations. Activated charcoal is recommended if the patient comes in within 1 to 4 hours post-ingestion, although the current trend is giving it at within 1 hour post-ingestion. Although activated charcoal has not known if it improves clinical outcomes such as risk for hepatotoxicity. The use of activated charcoal among paracetamol poisoning has significantly declined over the years, in part due to initiation of N-acetylcysteine early during the treatment. In the study by Chu et al. In Australia, among patients with paracetamol poisoning between September 2013 and April 2015, using more than 40 grams of paracetamol as the arbitrary definition for massive paracetamol overdose, they found out that using charcoal within 4 hours post-ingestion was associated with significantly reduced initial paracetamol concentration and may have also interfered with subsequent absorption or increased clearance, thereby resulting in reduction in hepatotoxicity. And in those with high paracetamol concentrations, increased acetylcysteine treatment within 21 hours results in significant reduction in hepatotoxicity. So the study also confirms that very high early paracetamol concentrations are independent risk factors for hepatotoxicity, even when acetylcysteine is given. Okay, so the second trend is the use of the 3-bag versus the 2-bag protocol, no? So in paracetamol overdose, NAPQR or N-acetyl-P-benzoquinone imine is produced, which causes depletion of glutathione and covalently binds to cellular proteins, resulting in hepatotoxicity. So the role of the antidote in paracetamol overdose is to replenish glutathione and detoxify NAPQI. In the 1970s, several antidotes were evaluated, including methionine, cysteine, cysteamine, and dimercaprol. Cysteamine and methionine have been shown to decrease the risk for hepatotoxicity in several RCTs. Cysteine was associated with headache, nausea, and vomiting. And later on, they found out that IV acetylcysteine was found to be equally effective with as cysteamine and methionine, but with lesser side effects. And since then, acetylcysteine has been the mainstay of treatment for paracetamol poisoning. However, acetylcysteine has been shown to have adverse effects ranging from nausea and vomiting to cutaneous hypersensitive reaction, bronchospasm, and even death. No, so there are several protocols used in paracetamol poisoning, but all of which have a total of acetylcysteine infusion of 300 milligrams per kilo over 12 to 21 hours, depending on the protocol used. So the only difference is the rate of infusion. So we have the traditional 3-bag protocol, which started with a loading dose of 100 milligrams per kilo over 15 minutes, followed by 50 milligrams per kilo over 4 hours. And then the third bag would be 100 milligrams per kilo over 16 hours. So this has been revised to the 3-bag protocol with a 60-minute loading dose, which we use currently in the Philippines. No, so the 3-bag protocol with the 60-minute loading dose differs with the first traditional 3-bag protocol, in which the first bag or the loading dose is given over 1 hour instead of 15 minutes. And then we have the 12-hour modified protocol or the SNAP protocol. So this is a 2-bag protocol. The first bag would be, or the loading dose would be given at 100 milligrams per kilo of N-acetylcysteine over 2 hours, followed by 200 milligrams per kilo over 10 hours. And then recently, we have the 2-bag protocol. So this is given at 200 milligrams per kilo over 4 hours, followed by 100 milligrams per kilo over 16 hours. So both traditional 3-bag protocols were associated with adverse effects due to the high initial peak of acetylcysteine concentration as shown in this graph. Okay, so this figure shows the different studies on the adverse effects due to the traditional 3-bag protocol and its modifications. So despite prolonging the loading dose to 60 minutes, there are still adverse effects noted. So here in the Philippines, specifically the Hospital ng Makati, headed by Dr. John David Comandante, they started using the 2-bag protocol in 2022. And they found out that among those patients who were given the 2-bag protocol, there were no reported adverse events as compared to using the 3-bag protocol where they reported 7 patients out of the 47 patients had adverse drug events. So the next trend is the doubling of NAC in massive paracetamol overdose. Okay, so for massive overdose, studies have shown that patients who have massive overdose or those who have concentrations above acetaminophen concentrations above the 300 line develop hepatotoxicity at a higher rate than those below the 300 line. Several studies suggest that both hepatotoxicity and liver failure increase with acetaminophen concentrations above the 300 and 450 lines and suggest the need for higher doses of N-acetylcysteine for these thresholds after the loading dose. So the current 3-bag protocol delivers 12.5 milligrams per kilo per hour over 4 hours after the loading dose, then 6.25 milligrams per kilo per hour over 16 hours. However, in massive overdose patients who have, or for those patients who have concentrations above the 300 line at 4 hours post-ingestion, studies recommended the use of doubling of the dose of N-acetylcysteine. So this protocol was first described by Rumack and Bateman in 2012, and it was demonstrated by Marks et al. In 2023 2013 in a retrospective review, extrapolated by Hendrickson in 2019, and adopted in the New Zealand and Australian guidelines for paracetamol poisoning. So based on the doubling protocol, so if the ingestion is between 16 and 32 grams, or the initial APAP concentration is between the 300 line and the 500 line, then consider using 12.5 milligrams per kilo per hour as the 16-hour infusion rate instead of the 6.25 milligrams per kilo per hour. So if the ingestion is between 32 and 48 grams, or the initial concentration is above the 500 line, then consider using 18.75 milligrams per kilo per hour as the 16-hour infusion rate. If the ingestion is greater than 48 grams, then consider using 25 milligrams per kilo per hour as the 16-hour infusion rate. And if the concentration at 20 hours or later is at 25 to 50 micrograms per ml, then use 12.5 milligrams per kilo per hour as the continuous infusion. And if the concentration at 20 hours or later is more than 50 micrograms per ml, then use 18.75 milligrams per kilo per hour as the continuous infusion. So you can do this by combining IV N-acetylcysteine plus oral N-acetylcysteine to complete the recommended infusion rate. Okay, so for the last part of my presentation, I will be discussing the management of acetaminophen poisoning in the US and Canada. So this is a consensus statement by the United States and Canada. So as discussed earlier, paracetamol poisoning is still one of the leading causes of poisoning. And since the 1970s, there have been a lot of changes in paracetamol poisoning, including emergence of different preparations and concentrations of paracetamol that are available in our market, variations in management guidelines, stemming from variability in resource availability, patient behaviors, clinical outcomes, and staffing of poison centers and emergency departments, as well as medical specialties managing poisoning. So this consensus statement is the first clinical practice guidelines for poison centers and emergency departments in the United States and Canada. So this was conducted between March 2021 and March 2023 and was published in the Journal of American Medical Associations last August 2023. So there were 21 panel experts chosen by the leading clinical toxicology organizations in the US and Canada. So that includes the American Poison Centers, the American Academy of Clinical Toxicology, or the AACT, the American College of Medical Toxicology, and the Canadian Association of Poison Control Centers. So they reviewed 84 guidelines and 278 publications. So most of the guidelines meet evidence quality 5, that is properly conducted, opinions of respected authorities and case reports, and only 7 articles met quality 1, which is properly conducted RCTs and systematic reviews with meta-analysis. Okay, so for the first consensus statement, which is the management of suspected acute ingestion of immediate release acetaminophen products, review of literature showed that there were only few reports that evaluated the procuring of an accurate history for acute ingestion. Hence, the panel defines unreliable or inaccurate history as lacking sufficient detail to establish dose and time of ingestion, that contains conflicting statements, or when the patient has symptoms, signs, or laboratory values inconsistent with the history, or the physician has doubt in the history provided to him or her. And there are also variations in the definition of acute ingestion, from a single ingestion for a period of 1 hour to 8 hours or another period. So the Rumac-Matthew nomogram, which we use to determine treatment with acetylcysteine, is only applicable for acute ingestion. And in the source publication, the Rumac-Matthew nomogram, acute ingestion was defined as history of known or suspected ingestion of 7.5 grams or more of acetaminophen within 24 hours of admission. So the panel defines acute ingestion as any ingestion within a period of less than 24 hours, regardless of the ingestion pattern. And repeated supratherapeutic ingestion is any ingestion occurring during a period of more than 24 hours. Okay, so this is the pathway for the management of acetaminophen poisoning in medical facilities. So if the patient comes in with a reliable history and acute ingestion, as any period of ingestion from 0 to 24 hours, then we do gastrointestinal decontamination with single dose activated charcoal within 4 hours post ingestion. And then we request for acetaminophen concentration. So if the patient has an total ingestion of more than 30 grams, then we start, or if the acetaminophen concentration level will come in later than expected, then we start with the acetylcysteine infusion. Okay, so once the acetaminophen concentration comes in, we plot it in the Rumac-Matthew nomogram. So if it is below the treatment line, then we discontinue with the acetylcysteine infusion, or we do not administer acetylcysteine infusion. Reconsider as accuracy of history if there is elevation of your liver function test, despite the acetaminophen concentration below treatment line. So if it is above the treatment line or above the high-risk line, then we continue or administer acetylcysteine. And consider increased dose for high-risk ingestion. There is a stopping dose, stopping criteria for acetylcysteine, which will be discussed later on. Okay. And then we repeat our laboratories before we end the infusion. For patients who have unreliable history, we do not do gastrointestinal decontamination. Instead, we do the serum acetaminophen levels and the complete metabolic panel. So if the acetaminophen concentration is more than 10 micrograms per ml, or the liver enzymes are abnormal, then we continue with the acetylcysteine infusion. And if it is less than 10 micrograms per ml and the liver enzymes are normal, unless the baseline is abnormal, then we do not administer acetylcysteine. Okay, so the panel choose to revise the Rumac-Matthew nomogram by including only lines that guide clinical action. So the blood concentration of acetaminophen is simply plotted on the nomogram, and acetylcysteine is administered to patients whose concentration is above the treatment line. So the original Rumac-Matthew nomogram derived from patient data begins at 200 micrograms per ml at 4 hours post-ingestion. However, in the consensus statement, the treatment line or the safety line begins at 150 micrograms per ml at 4 hours post-ingestion, which was derived as 25% lower than the original nomogram. A line beginning at 300 microgram per ml at 4 hours was derived as 50% higher than the original nomogram line to denote patients with increased risk of developing liver injury. So acetylcysteine should be initiated if the plasma acetaminophen concentration drawn between 4 to 24 hours above after ingestion falls on or above the treatment line. So if the concentration falls below the treatment line, then we do not give acetylcysteine. Okay, so for the administration of acetylcysteine, so acetylcysteine can be administered either orally or intravenously. So the initial dose should be administered as soon as the need for treatment becomes evident, either through a reliable history or a serum concentration, serum paracetamol concentration. So the panel literature review showed more than 15 different regimens were identified, but the comparative effectiveness of this regimen has not been evaluated. The panel recommended use of a regimen that delivers at least 300 milligrams per kilo orally or intravenously during the first 20 to 24 hours of treatment. The guidelines codifies the practice of acetylcysteine stopping criteria. So they found out that a common clinical error is to administer acetylcysteine for a period of 20 to 21 hours and then discontinue without reassessment of the patient. However, some patients require longer treatment. So the recommended practice is to administer acetylcysteine until stopping criteria are met. So the panel recommends the following as stopping criteria. So acetylmen concentration of less than 10 micrograms per ml, INR of less than 2.0, liver enzymes, which is normal for patient, or if elevated have decreased from the peak by at least 25 to 50%. And of course, the patient is clinically well. So if the stopping criteria are not met, then we continue with IV and acetylcysteine at a rate of at least 6.25 milligrams per kilo per hour. Or this is the traditional third bag infusion. And then withdraw acetaminophen concentration and complete metabolic panel every 12 to 24 hours. And then we reassess if the patient has fulfilled the stopping criteria. So if the criteria are met, then we discontinue the N-acetylcysteine infusion. But if the patient is still has not met the stopping criteria, then we continue with the N-acetylcysteine treatment. So stay same rate, no, at 6.25 milligrams per kilo per hour. So the next consensus statement is on the high-risk acetaminophen ingestion, and they define this as ingestion of at least 30 grams of acetaminophen or an acetaminophen concentration above the high-risk line on the nomogram, which is at 300 micrograms per ml. So high-risk acetaminophen ingestion are managed similarly with acute ingestion of paracetamol patient, no. However, they recommend considering increasing the acetylcysteine dose. So and they also recommend administration of activated charcoal longer than 4 hours post ingestion, owing to the delayed absorption. So aside from the acetaminophen concentration, complete metabolic panel in other laboratories should also be included depending on the patient's clinical presentation. So for high-risk acetaminophen ingestion, you can still use the doubling of NAC protocol. Okay, so again, this is the pathway for management of acute poisoning. Acute ingestion, sorry. Okay, so the next statement is on patients with supratherapeutic ingestion. So repeated supratherapeutic ingestion is defined as multiple ingestions for a period greater than 24 hours. Unlike patients with acute ingestion, management is determined by the patient's presentation. So if the patient's acetaminophen concentration is greater than 20 micrograms per ml, or the liver function tests are abnormal, acetylcysteine should be administered until the stopping criteria are met. Similarly, if the acetaminophen concentration is less than 20 micrograms per ml and the liver enzymes are normal, unless the baseline for the patient is not normal, then we discontinue, we do not administer acetylcysteine. So for patients with ingestion of extended release acetaminophen products, which is defined as acetaminophen products available in the US or Canada and labeled for use on an 8-hour basis, management is the same as for ingestion of other acetaminophen products, except that activated charcoal may be used longer than 4 hours, similar with massive paracetamol overdose. Especially if patients has evidence of ongoing absorption of paracetamol, as evidenced by increasing acetaminophen concentration. So if the acetaminophen concentration was drawn between 4 to 24 hours after ingestion is above the Rumac-Matthew nomogram treatment line, so acetylcysteine is needed. However, as compared to the acute ingestion of immediate release, if the concentration samples drawn between 4 to 12 hours after ingestion is below the treatment line but above 10 micrograms per ml, it should be measured again 4 to 6 hours after the first measurement. But the management will still be the same. So the next statement is on co-ingestion of acetaminophen and anticholinergic or opioid agonist medications. So for this, the clinical concern is that absorption may be delayed or prolonged. So management is still the same with other acetaminophen products, except that the first acetaminophen concentration measured at 4 to 24 hours post-ingestion is less than or equal to 10 micrograms per ml. Another measurement may not be taken, and acetylcysteine may not be needed anymore. So if the concentration is above treatment line, then we proceed with an acetylcysteine infusion. So the dose and duration of acetylcysteine infusion is still the same with acute ingestion of immediate release. So the last consensus statement are for those overdose among special populations. So for patients weighing more than 100 kilograms, the management is still the same as any acetaminophen product ingestion. However, the acetylcysteine dose calculation is capped at 100 milligram per kilo. At 100 kilogram body weight. For patients who are younger than 6 years old, the management is still the same for older patients, except that the clinician should simply contact their poison center or clinical toxicologist if a child receives a single intravenous dose of acetaminophen of 90 milligrams per kilo body weight or a cumulative dose of greater than 150 milligrams per kilo body weight during the 24-hour period. With some regimens, adjustment of acetylcysteine requires weight-based adjustment to avoid hyponatremia for patients who weigh less than 41 kilograms. So for pregnant women, the standard evaluation and management of acetaminophen poisoning is still the same with non-pregnant women, except that some clinicians prefer the use of intravenous route for acetylcysteine administration to lessen the adverse effect. So the use of enhanced elimination techniques is recommended when a very large ingestion has occurred. The consensus panel concurred with the extracorporeal treatment of poisoning that hemodialysis is recommended in addition to treatment with acetylcysteine in patients with an acetaminophen concentration of 900 micrograms per ml or greater with or for those patients with acidosis or altered consciousness due to acetaminophen toxicity. Consultation with liver transplant team for possible liver transplant should be considered in patients with progressive increases in liver enzymes and coagulation abnormalities. So liver transplant team consultation should be also considered in patients with encephalopathy or multi-system failure despite acetylcysteine treatment. So in summary, we have discussed the paracetamol poisoning and its current trends. So we discussed current management strategies for paracetamol poisoning as well as new therapeutic strategies in the management of paracetamol poisoning. So I think this is my last slides. Thank you for listening.
Thank you so much, Dr. Jennifer, for your comprehensive and enlightening presentation on paracetamol toxicity. Okay, you have truly highlighted the critical aspects of the diagnosis, risk assessment, and managing overdose cases in clinical setting. Your expertise and insights, particularly on toxicological management, will certainly aid healthcare professionals in navigating such cases more effectively. On behalf of the entire team and our participants, we sincerely appreciate your time and dedication. Let's give Dr. Jennifer another virtual round of applause for sharing her expertise with us today. Thank you so much, Dr. Jennifer.
Thank you.
Now it is my great pleasure to introduce our next distinguished speaker, Dr. Taufiq Abdullah. Dr. Taufiq is a clinical lecturer and emergency medicine specialist at the Department of Emergency Medicine, Faculty of Medicine, Universitas Brawijaya, Indonesia. With extensive expertise in toxicology and emergency care, Dr. Taufiq has played an important role in the development of toxicology services and education in Indonesia and the region. Dr. Taufiq's dedication to the emergency medicine is evident through his impressive career spanning over a decade. He is actively involved in toxicology research, emergency care education, and has been a key speaker at numerous national and international seminars, sharing his expertise on the management of toxicological emergencies. Today, Dr. Taufiq will be presenting on a highly relevant and important topic, toxicology screening profile on trauma patients in Saiful Anwar Hospital. This presentation will shed light on the critical role of toxicology screening in trauma cases and its implications for the patient outcomes in emergency setting. Without further ado, please join me in welcoming Dr. Taufiq Abdullah. Dr. Taufiq, the screen is yours.
Good morning. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity to speak today at the 6th Emergency Medicine Seminar Series. I would also like to express my sincere gratitude to our moderator, Dr. Muhammad Azari from the Department of Emergency Medicine at Hospital Consular Tuanku Inggris, CKM, Malaysia, for this kind introduction and for facilitating this session. It is an honor to be here and share insights with such a distinguished audience. Today, I will be presenting our mini research on our emergency department, Saiful Hospital, about the tox profile screening in trauma patients. As you know, comprehensive toxicology screen are commonly employed in many emergency department and trauma service. Their primary role is to assist in the differential diagnosis of patients who present with mental status changes. While several studies have highlighted inconsistency between patient history, physical examination, and the actual substances ingested in emergency settings, there is ongoing debate about the cost-effectiveness of conducting routine comprehensive tox screens, particularly in trauma patients. So it can be challenging to differentiate between causes of mental status and vital sign abnormality in trauma patients, whether due to head injury, hypovolemic, or cardiogenic shock, substance abuse, or a combination of many factors. As a result, many patients will undergo multiple diagnosis and therapeutic procedures even before the comprehensive toxicology is available. This emphasizes the need for the rapid intervention in critical settings. According to the Global Surgery Report on Road Safety 2023, an estimated 1.19 million road traffic deaths occurred in 2021. This equates to a rate of approximately 15 road traffic deaths per 100,000 people. These figures highlight the ongoing critical issue of road safety worldwide, necessitating coordinated effort in prevention and policy changes. A recent report from the WHO released in June 2024 emphasizes the significant mortality burden to alcohol and psychoactive drug use. It estimates that 2.6 million deaths per year are attributable to alcohol consumption, accounting for 4.7% of all global deaths. Additionally, around 0.6 million deaths per year are related to the use of psychoactive drugs. What is particularly striking is that 2 million alcohol-related deaths and 0.4 million drug-related deaths occur among men, making this again a public health concern. Beyond the direct effect of individuals, alcohol consumption causes extensive harm to others. A significant proportion of the alcohol-related disease burden is due to injuries, especially those resulting from road traffic accidents. In 2019, of the total 298,000 deaths caused by alcohol-related road crashes, and outgoing 156,000 deaths were due to someone else drinking. This starkly highlights how alcohol consumption contributes to preventable deaths and injuries that affect not just the drinker, but innocent bystanders as well. From the picture, one of the most striking insights from the data is that road injury ranks as the leading cause of death for individuals aged 5 until 29 years globally. This age group, which typically encompasses children, teenagers, and young adults, faces a disproportionately high risk of death due to road-related incidents. And then the data from both graphs emphasizes that road injury continues to rank among the top 10 leading causes of the death in lower middle income and upper middle income countries in 2000 until 2019. From the Global Status Report on Road Safety 2023 reports approximately 10% of road traffic deaths are related to the driving. This corresponds to self-reported rate of 16 until 21% of people admitting to drink driving in a survey conducted by the European Survey Research Association. And then from the data from Indonesia, from the Ajith Hospital, report that the most deaths due to influence of alcohol consumption occurred due to traffic incident, as many as almost more than 50% is with a range of alcohol content at 361 until 400 milligram percent, as many as 39 finding. So this is the reason that's why our hospital want to make research depend on the data. As we know, we have three levels. One to use the tox screen. Level 1 is urgent quantitative or semi-quantitative analysis. Especially you want to test the illicit drugs like acetaminophen, carbon monoxide, hemoglobin, or meth, digoxin, ethanol, lithium, salicylate, sulfiran, and other. And then the level 2 can use the chromatography assay or immunoassay. Of course, this test is very fast and sensitive method, and then we can look at the substance more specific. And then the third level in many countries is using the text herbal toxin or new or uncommon substance use. And if we use the urine immunoassay for drug use, the tests often do not get immediate medical management as they indicate exposure to a drug rather than acute poisoning or the severity of intoxication. A positive result does not necessarily mean that the detected substance is causing the current symptom. And then positive results can persist for days to weeks after exposure. The reason of drug so this assay may reflect past exposure and can remain positive for days to weeks after the substance was placed. This prolonged detection window can complicate the interpretation, especially in emergency setting, where the focus is on current, let's say in acute intoxication. And how about the high cross-reactivity and not specificity? This test rely on antibodies to recognize specific drug molecule, but they can be highly non-specific due to cross-reactivity. Like cyclic antigen assay drug may cross-react with many common drugs like carbamazepine, promethazine, or antipsychotic drugs, or other antipsychotic drugs. The Ketamine assay may cross-react with the dextromethorphan or benzodiazepine as they cannot detect certain diazepam like lorazepam. So from our data, we collect total patients. We have 160,200 patients, and then from that we have 2,745 trauma case. And then this indicated that trauma accounted for a notable portion of the department's case during this period. Currently, there is no standard operating procedure in place in our ED to routinely screen trauma patients for alcohol and illicit drugs. So it is represent a potential gap in trauma care management, especially considering the known association between substance use and traumatic injury, especially because of road accidents or violence. Developing on standard procedure for this screening to enhance the detection and management of substance-related trauma, leading to more tailored and prevention for affected patients. Our goal is to determine the prevalence and occurrence of alcohol and illicit drug use in patients with major trauma in the Anwar Hospital on June until August 2000 until 2024. This is our method. This research we collected 3-month observational disease study was conducted focusing of all trauma patients admitted to the red zone with a diagnosis of multiple trauma. Of course, we use the prospective study. And then from the inclusion criteria, we collect all trauma patients who were admitted in red zone with a diagnosis of trauma and age more than 18 years old with onset less than 12 hours after the trauma incident happened. And then from the exclusion criteria, from the pediatric trauma and patients who are not willing to participate in this study after informed consent is changed. The toxicology screening have to detect the presence of alcohol, specifically ethanol and methanol, and a range of illicit drugs, including benzodiazepine, amphetamine, methamphetamine, marijuana, and opiates. And then from the sample, we collecting 2 from the blood and urine. The sample test for the ethanol and urine test for the ethanol, methanol, benzodiazepine, amphetamine, methamphetamine, marijuana, and opiates. And then from the sample were analyzed at forensic laboratory in Saiful Anwar Hospital. Using the following methods: alcohol detection conducting using a qualitative test for dichromate oxidation, which allows for the identification presence of ethanol and methanol. And then illicit drug testing performed using the Aquan test kit. This is the standard test for in our forensic laboratory, rapid test that provides result on various types. From the data collection for this study, post-screening 1,116 trauma patients. Out of this, 651 patients were classified as a non-traffic collision patient and thus excluded from the study. This left 465 traffic collision patients eligible for further evaluation. We applied exclusion criteria to refine the sample. Further, 89 patients were excluded because they were under the age of 18, and then 319 patients declined participation in this study, and this led to 60 patients meeting the eligibility requirement. However, during the final review, 2 patients were identified as non-eligible, resulting in a final sample size of 57 eligible patients for this study. And then from the characteristics patient, we have collected the majority of the patients were male, accounting for 44 patients, while females comprised 13 patients, with the mean age 34 years old. And then from the median refined trauma score was 8, with the uninterrupted range of 1. And we have 15 patients were admitted to the operating room, 70 patients were admitted to a low care unit, 14 patients were admitted to high care unit, 2 patients were admitted to the intensive care unit. And unfortunately, 1 patient died and 8 patients self-discharged. And about the referral status, the 35 patients were referred by another healthcare provider, and 22 patients were self-referred in our ED. And then from the blood test alcohol, we have result. Blood 8 patients test positive for blood ethanol, and 2 patients test positive for urine ethanol. And then 16 patients test positive for urine methanol. And in total, 23 patients test positive for either ethanol, methanol, or both. And then for the illicit drug, we have benzodiazepine positive, 6 patients. And then 1 patient test positive for amphetamine, 10 patients test positive for methamphetamine. And then 1 patient marijuana positive, and 1 patient test positive for the opiate. And then 3 patients were found positive for 2 or more drugs, and 7 patients test positive for both alcohol and drugs. So based on data, as you know, the alcohol consumption level in Indonesia is very low when compared to the consumption other birth and also when compared to the other countries. The Ministry of Health conducted a survey in 2014 and found that only about 0.2% of the entire population consumes alcohol coverage from the 500,000 Indonesians. In the study, a discrepancy was found between positive blood ethanol and urine ethanol results with differences of 8 and 2 respectively. This discrepancy is possible caused by perhaps from the metabolism and elimination, timing of sample collection, or influence of hydration and kidney function. As we know, the ethanol is metabolized in circulated in the blood, then excreted through the urine. That typically show higher ethanol level shortly after consumption, while urine might reflect ethanol concentration with some delay. Differences in the timing of blood and urine sample collection can affect results, as ethanol level in the body fluctuated time. So, but the status ini, function and hydration, of course, an individual hydration level and kidney function can influence ethanol concentration in urine. But ethanol level are more directly related to upfront ethanol level. And then from the prevalence of alcohol illicit drug use, we have 23 testing positive for alcohol and 7 testing for both alcohol and illicit drugs. Of course, the qualitative test can detect the presence of multiple illicit drugs. Various drugs are detectable in the urine for varying amount of time, and this result requires careful interpretation and clinical correlation. After urine screen may result in positive for a prolonged period after use or clinical effect perhaps. Be careful if you want to do this qualitative test, because like the cocaine test detects the metabolism soil exonin quite correctly with not much concern for false positive or negative, but the metabolism might be present up to 3 days after use while having most critical effect within 6 until 12 hours of use. Amphetamine or methamphetamine test manifold positive amphetamine exists, including antihistamine, recognizance, antidepressant, or acetylcholine, and might be detected 1 until 3 days after use. And marijuana test common over the counter analgesic like ibuprofen and naproxen can cross-react with this assay, creating false positive too. And penicillin and false positive exist, notably with ibuprofen, dextromethorphan, and tramadol. And the time for detection can last 1 until 2 weeks after use. about the opiates can be missed and routine screening, generating significant false negative and the report of false positive results in the presence of herbicides and quinoline antimicrobials and detectable for 1 until 4 days. And benzoiazepine results are likely among the least clinically used screen. A few false positives exist, but false negatives are far more common, as most assays detect the specific hepatitis form, while multiple benzodiazepine with new metabolites are likely to be missed. Diazepam is metabolized to azepam and will be identified, but might be present for up to 4 weeks after use. On the other hand, metabolism lorazepam so other substance and therefore both demand undetected. Of course, from our data results, we have limitation. Especially toxicology screening in this study provides only qualitative results, and the sample size examined tend to be small, as many patients raised to participate in the study. This may potentially affect the prevalence result in this study. The result of the study is the most popular substance of use in our study of multiple trauma patients presented to our ED. And was the more that the final data is the can collect the alcohol and methamphetamine result. As none of the patients in this group had initially the treatment alterations in relation to their comprehensive screening. The screening does not appear useful in the acute menopause trauma patient. The use of toxicology screening in trauma can help to guide the management of chronic treatment, but urine and serum tests carry significant caveats that limit the clinical utility. So the conclusion, positive claims in trauma without clinical symptoms may reflect the detection of metabolites and previous use and not lead to any changes in management. Negative screen will often not be able to exclude the use of this substance. Urine tests give qualitative, presumptive results and need clinical interpretation. And serum tests give quantitative, presumptive results and need clinical interpretation, in addition to potentially obtaining repeat sampling for certain questioning. All toxicology screening in trauma patients must be interpreted within the context of patient and should not routinely be a procedure as either exclusionary or confirmatory aspected exposure. Thank you. This is the end of our presentation. Good morning.
Thank you so much, Dr. Taufiq, for delivering presentation on the toxicology screening profile on trauma patients in Saiful Anwar Hospital. Your discussion has truly highlighted the importance of integrating toxicology screening into the management of trauma cases in emergency settings. On behalf of all the participants and the organizing committee, I would like to extend our sincerest appreciation for your time and your dedication. We are incredibly grateful for your willingness to share your experience and insight with us. Thank you once again, Dr. Taufiq Abdullah. Thank you to all the participants that joined us so far. We have covered some fascinating topics in clinical toxicology, and I know we all appreciate the valuable insights from our speakers. Now, it's time for 45 minutes rest session as we are waiting for the Dr. Ajith Venugopalan from India. Because of the time difference, we are still waiting for the next speaker. So we'll be resuming the webinar at 10:30 a.m. So make sure to set your alarms or reminders. If you have any questions or thoughts you would like to share during this break, please feel free to jot them down and we'll address them when we come back. Enjoy your break. We look forward to see you all again at 10:30 a.m. for continuation of our exciting program. Welcome back, everyone. Today, we will continue our journey through clinical toxicology with our third speakers. Today, we are incredibly fortunate to have a distinguished speakers with us, Dr. Ajith Venugopalan, who will be sharing his expertise on a highly relevant and crucial topic, toxidrome and approach. Dr. Ajith is an expert in the field of emergency medicine, known for his extensive knowledge in managing poisoning and toxicological emergencies. With his years of experience, he has played a key role in educating healthcare professionals on rapid identification and management of toxic syndromes or toxidromes, which are pivotal in the emergency settings. Dr. Ajit now is Chief Operating Officer and Group Head and Senior Consultant at Caritas Hospital, Kerala. Dr. Ajit had a postgraduate diploma in medical law and ethics, fellowship in intensive care medicine, fellow of Academic College of Emergency Expert, numerous certifications from American Heart Association and other international organizations in life support and trauma care. Dr. Ajit also involved as event doctor for the FIFA World Cup 2022 in Qatar, member of the WHO Radiation Emergency Preparedness Network, lead instructor for multiple international medical certifications. Dr. Ajit has received various awards, including Best Paper Presentation Award during the first International Symposium on Hospital Medicine conducted in Kochi, among Academic Leadership Award 2020, and the latest Excellence Doctor Award 2024, awarded by We Care Foundation for the contribution to the emergency medicine and trauma care, including pre-hospital medicine during National Doctors Day. Dr. Ajit has also contributed to numerous research papers in the field of emergency medicine, toxicology, sepsis, and non-communicable disease. Dr. Ajit will provide us with insights that will help enhance our practice in recognizing the patterns of toxidromes and applying the right clinical approach. Please join me in welcoming Dr. Ajith Venugopalan as he takes the floor to present toxidrome and approach.
Thank you for that extensive introduction. I'm really honored to be a part of this program. And indeed, it's a great privilege that such an event has been conducted, that is inter-country and multiple country faculties and residents are attending the program. So it's indeed an honor to be present here and to be part of this academic event. So good morning once again to all. Today, greetings from Caritas Hospital and Institute of Health Sciences. It's in Kerala. It's a multi-speciality hospital with around 700 to 800 beds, which we cater to around 7 lakhs patients annum. This session, we are mostly handling the toxidromal approach in management of poisoning and overdoses. In general, everyone who is attending this session would have managed toxicological cases or poisoning cases at one point or other. Let's see how we can evaluate it in more an approach manner, and we manage it in together to solve cases. I'm Dr. Ajith Venugopalan, currently working as the Chief Operating Officer and the Group Head and Senior Consultant of Emergency Medicine and Trauma Care. Let's begin with a case scenario. We have a 48-year-old female, otherwise healthy, presenting to the ER in a drowsy state. Bystander gives history of a presence of an empty bottle near her. The content is unknown. She vomited. There is pungent odor present. How do you go about with these cases? These type of cases are routine scenario in any emergency department. We get confused seeing that empty bottle, whether it is an overdosage, whether it is poisoning, or at times that empty bottle may not be.
Dr. Ajit, sorry.
Yeah.
Can you help us to share only your slide? Because we cannot see the full of the slide. We cannot see the slide. Okay, all right.
Is it
Thank you, Doctor.
It's fine?
Okay.
Yeah,
Yes,
fine.
All right, thank you, Doctor.
Okay. Yeah, so most of these situations, we are trying to solve a puzzle. And these empty bottles may not be actually a picture at all. So we are treating a patient who is in a drowsy state with vomiting. So that is how the scenario can be. It can even be just a stroke. So the problem is toxicological scenarios are difficult to manage because of the fact that history is unclear, and if it is intentional poisoning or intentionally the patient has taken something, it is very hard to get the history out of them. So these scenarios are something that we are facing major concerns. So it can be ingested toxins, it can be inhaled toxins. So there is a number of toxicological manifestations and concerns that we have. And we also know about antidotes. So that's another picture about it, whether you need antidote, whether you don't need antidote. So together, all this makes treating an toxicological scenario much, much more challenging. So said all this, let's see that how we can manage or evaluate such cases. So the agenda of the session is to introduce you the concept, toxicromal approach, clinical toxicology, stabilization, concerns, bar issues, and recommendations. As we all know, all chemicals have potential to be poison if there is a large enough dose affected. And it definitely adversely affect the functioning of any organ system. As the grandfather of toxicology has always said, the dose makes the poison. All things are poison and nothing is without poison. Only the dose permits something not to be poisonous. This statement is really important when it comes to managing a case or when it comes to toxicology, because any drug that we prescribe in the therapeutic effect can lead to toxic effect if the dose is not adjusted properly. I'll tell a simple example. You take paracetamol for that matter. Paracetamol, we all know that for a pediatric dose, it is 10 to 15 mg per kg. But if you give an adult dose to a pediatric population for paracetamol, then that becomes a toxic effect. So it is only the dose that makes the poison. And that's one thing that we have to know in toxicology. So the risk is always hazard into exposure. Certain drugs, the exposure, if it is in minute quantity, may not be that much poisonous. But if the exposure is lasting, there is larger exposure, if the exposure is persisting, then it becomes more dangerous. So the principle of any toxicological management is divided into resuscitation and stabilization, reducing exposure, reducing absorption, increasing elimination, diagnosing type of poison, specific therapy or antidotes, and supportive therapy bar intensive care. The one most important thing that you have to understand here is resuscitation, stabilization, reducing exposure, reducing absorption, increasing elimination. These four things are done even if we have no clue what the poison is. Only thing that you need to, we don't need to have an exact diagnosis of what it is. Then only comes diagnosing the type of poison. And after all this, only comes antidotes. That means that antidotes is not the cornerstone of treatment of toxicology. Every time there are concerns that we go behind antidotes and we forget the principles of managing toxicology. Then comes the supporting intensity. So two take-home messages I would say from these slides is that diagnosing is not the first line of management of toxicological poisoning. And antidotes is not again the cornerstone of management of toxicology. So these 2 points are something that you all should be careful about. So evaluation and management of toxicology, I would say it is always the A, B, C, D, E, F, S method. That's something that I practice, and where you put the toxicological syndromes or toxidromal syndromes together, and you manage the case in this approach. Because time is essential, and each minute counts in toxicology. As we tell about the golden hour and the platinum minutes in managing trauma, it is also pivotal to understand that even in toxicology, minutes count. If you all know that activated charcoal should be given within 1 hour in certain selected cases, that 1 hour is important. Similarly, if a patient comes with certain types of toxins, the patient require hemoperfusion within as early as possible. So time is definitely crucial when it comes to toxicology management. And majority of time, we are playing with a big question mark. We have no clue what has happened. The history may not be completely relevant. We may not be having enough data to support ourselves. We may not be having enough informations about what is happening. So each second counts, and because we are dealing with big question mark. So what is the picture of toxicrome? Toxicrome is equal to a toxicological syndrome. And it is basically a method where you use rapid clinical diagnosis and targeted therapy. These are things that gives importance when it comes to managing a toxicity. The patient history, the vital signs, targeted physical examination, a rapid bedside lab test, whatever is required, metabolic panels like glucose, acid-base balance like ABG and all those things, and ECG. These gives a primary clue about how do you manage forward. So it is the four circles which comes and together meets at one red spot, and which makes the difference in managing toxicology. History, symptoms and signs, simple dabs, and vital signs all should merge together to help you manage toxicological syndromes. So toxicological syndromes or toxidromes are broadly divided into 9 types: opioids, sedative hypnotics, hypoglycemics, serotonins, salicylates, anticholinergic, cholinergics, sympathomimetics, and hallucinogenic. So these are the different divisions when it comes to toxicromes. And how do you come into that? If it is an opioid, any patient that comes to you with meiosis, any patient who comes to you with meiosis should trigger an thought process where the patient is having an opioid overdose. So meiosis combined with respiratory depression, combined with CNS depression, along with hypothermia and bradycardia, should always give us a clue about a codeine or a heroin or a morphine toxicity. So opioids will present to you with meiosis along with respiratory depression and CNS depression. At the same time, sedative or hypnotics again is depression, sedations. We all know that why we give sedatives. We give sedatives so that the patients can comfortably sleep. And that sleep is basically CNS depression. But the problem is, if that sedation goes beyond certain time, if that sedation goes beyond patient's comfort time, then what happens is that it goes to respiratory depression because it has affected the brainstem. So now when it goes to respiratory depression, the next area it is going to affect is the CNS and CVS center, which will produce bradycardia. So sedatives and hypnotics are CNS depressing drugs, which will target CNS depression to begin with. Then it goes to respiratory depression. Then it goes to bradycardia. Then you may have ataxia and dysarthria. So that is where sedatives or hypnotics like benzodiazepines, barbiturates come in play. Then we have another whole group of hypoglycemic. Hypoglycemic is something that we all are common with. Any patient who comes with altered mental status, sweating, tachycardia, hypertension, so basically autonomic hyperactivity, should trigger an hypoglycemic episode. It can also have behavioral changes, dysarthria, and seizures towards the end of it, but it may not be the primary presentation. So altered mental status with sweating, with tachycardia and hypertension should always give you a clue of hypoglycemic agent. That can be sulfonylureas or insulin overdose. And that is something that you need to manage immediately. Each second is going to count when it comes to managing hypoglycemic agents. Then there is another picture altogether, serotonins. Serotonins are drugs like SSRIs, MAO inhibitors, tricyclic antidepressants, amphetamines, pentas. These are drugs which understand this very clearly. We have told about earlier antidepressants, and we have talked about benzodiazepines and drugs like that. But here, the difference is that when it comes to serotonins, it not only produces altered mental status, but also starts playing with the muscle tone. It starts playing with the reflexes. It starts playing with the tachycardia and hypertension and flushing and all those other things. So if you're thinking about any patient coming to you with altered mental status, with patient is having hypertonia, patient is having hyperreflexia, along with the patient is having clonus or tachycardia or diaphoresis, then it should always trigger you there is a possibility of serotonin or serotonin syndromes. So that is SSRIs, MAO inhibitors, tricyclic antidepressants, all comes in the class of serotonins. So be very careful because this may be the only clue. The hyperreflexia and hypertonia may be the only clue that helps you to go in managing serotonin syndromes. Then we have a totally different class of salicylates, aspirin. Aspirin, we all know that people take aspirin commonly, but aspirin overdose. Again, the patient starts with altered mental status, but here patient becomes tachypnic. Patient becomes tachypnic. The patient will have respiratory alkalosis with metabolic acidosis. So patient who is having altered mental status with respiratory alkalosis, with tachypnea, with metabolic acidosis, along with tinnitus, tachycardia, and all those other things, should give us a clue of aspirin. So aspirin, you have to think about three A's. Aspirin, you have to think about three A's. Altered mental status, alkalosis, that is respiratory, and acidosis, that is metabolic, along with tachypnea. So think about this when it comes to ABG findings or ABGs to have that much respiratory alkalosis, because that is the mechanism in which patient is going to breathe very fast, so that this combination, the drug metabolism has an effect with it. Hence, even when you're intubating a patient with salicylate poisoning, you should not make the patient go into respiratory acidosis, meaning the patient who is having a birth rate of 20 to 30, you should not bring that birth rate to 15 or 14. And then the patient becomes more metabolic acidotic and the patient's salicylate absorption starts increasing more. So it is important that that respiratory alkalosis is maintained till the patient is stabilized more. So that is about salicylate. Now our very common South Indian or maybe Indian toxin is anticholinergic. The atropine, the antihistamine, antipsychotics, basically something that we commonly say as hot as a hair, dry as a bone, red as a beet, and mad as a hater. So basically, hot is patient is totally flushed. Patient is having hypothermia, a toxicological manifestation where the patient is having hyperthermia should give us a clue it is anticholinergic. Dry as a bone, patient is dry, decreased bowel movement, decreased urinary movement. That's something that you have to think about. Red as a beet, again the patient is flushed. Patient is having, again as I told, hypothermia. The patient can go to rhabdomyolysis. And last and most important thing, mad as a hater. The patient is having altered mental status. Patient can have seizures. So any drug or any presentation where the patient is having altered mental status with mydriasis, another clue, with mydriasis. I told that certain drugs may have, narcotics can have meiosis. So here the patient is having mydriasis. Patient is dry. Patient is having bowel movements reduced, urinary movements reduced. And these should give us a clue of anticholinergic. Then is the cholinergic, the straight opposite, where the patient is having salivation, lacrimation, urination, diarrhea, gastric emesis, vomiting, and diaphoresis. There's something that we commonly called as sludge BBB. S for salivation, L for lacrimation, U for urination, D for diarrhea or defecation, G for gastric emesis or vomiting, and E for emesis, and BBB is bronchoria, bradycardia, and the patient will have meiosis. So something that will straight opposite of cholinergic, anticholinergic, where we have told about everything going dry. In cholinergic, everything goes wet. We have like everywhere the patient will be sweating. Patient will be salivating. The patient will be literally drenched in sweat. So two things that you have to think about when the patient is drenched in sweat is one is cholinergic toxicity. The other was the hypoglycemic episode. So only difference that you go with both is that here when you look at the pupils, the patient is having meiosis, and also the patient is having chest will have severe symptoms. There will be bronchoria and bronchoconstriction. Whereas when it comes to hypoglycemic, the chest will be mostly clear to begin with, and also here patient will have starting to have bradycardia. So here, sludge or cholinergic, it will be mostly secretions will increase drastically, and you have to think about how that secretions has increased and you have to manage. So this is organophosphorus poisoning, very common in India, where or very common in places where you're going to use it as pesticides. Now come to sympathomimetics, like amphetamine, cocaines, and things like that, which is going to trigger you, which is going to make you that feel good feel, where the patient will have agitation, tachycardia, hypertension. So all the sympathetic hyperactivity will have, and then there will be hyperpyrexia. Then it can even lead to acute coronary syndrome. So agitations and tachycardias and hypertension to begin with, then hyperpyrexia and diaphoresis to go with. So this is sympathomimetics. And the last is hallucinogenics. Hallucinogenics, the patient will come to you or talk to you in a patient will be hallucinating. Patient will be telling you things which is actually not present. Patient will be anxiety will be there. Patient will have nausea. And the patient will also have symptomatic signs, that is tachycardia, agitations, hypertension. So difference between sympathomimetics and hallucinogens is that patient will have that hallucinogenic episodes, and that is where it is a clue that you have. And whether it is common, yes, you may come across it once in a while. So putting all together, the toxidromes, as I told, is divided into 9: opioids, sedatives, hypnotics, hypoglycemics, serotonin, salicylates, anticholinergic, cholinergics, sympathomimetics, and hallucinogens. Think about CNS depression with myos when it comes to opioids, CNS depressions in sedatives, alternative status sweating for hypoglycemic, alternative status with reflex increase for reflex and tone increase for serotonins, alternative status with tachypnea, with metabolic acidosis, with respiratory alkalosis for salicylate, alternative status with dryness for anticholinergic, sludge BBB for cholinergic, agitation, tachycardia, and hypertension for sympathomimetics, and hallucinogenic effects for hallucinogens. So this is in nutshell about the toxidromal approach. And coming to the putting all together, putting this into clinical management, how do you manage these cases? So as I told earlier, it is about managing the ABCDEFS method. So when it comes to managing the ABCDEFS method, it is important that you are going to stabilize certain things first. The first priority is always first. And that is where it is going to manage your clinical management changes. And it is always, 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 safety of the caregiver is important. Use adequate PPE as required, depending on the situation that you are going to play with. If it is totally unknown, or protections. If it is unknown or if it is known, consider according to what you have. So it is important that your safety is of utmost importance. So when it comes to airway, majority of time in toxicology, airway is given least importance. And that is something that we all need to understand. Airway always, 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 always takes priority. And clearing the airway, because certain toxicological manifestation can have secretions, certain manifestations can have decreased respiratory, depressions can have. So clearing the airway, taking airway into priority, rapid sequence intubation is required. And when you're intubating, use non-depolarizing agents, use coronium or atracorium or vecuronium. Don't use succinylcholine, because depolarizing agents in like in OPs, organophosphorus, cocaines, and digoxins can have negative effect. So better use non-depolarizing agents, because we don't know what it is. Then C-spine protection if required, because again, these patients would have come to you with history of fall and things like that. Again, you have no clue what has happened to the patient. So it is always better to manage such cases with a C-spine protection. When it comes to breathing, you need to know how to monitor, how much oxygen to give, how do you give oxygen, and when to go for definite airway. Monitor respiratory rate saturation, chest signs, oxygen should be maintained more than 94%. Hypoventilation should be avoided. And risk of aspiration is always high in every case of toxicology. So you have to understand that, you have to manage that effectively. Aspiration of hydrocarbons, kerosene will lead to chemical pneumonitis. So it need not be patients has ingested it, even the fumes will lead to chemical pneumonitis. So understand that also when it comes to aspiration of hydrocarbons. Salicylate maintain high minute ventilation, as I told earlier itself. Respiratory alkalosis is one protective mechanism of when it comes to salicylate. So maintain high minute ventilation in such cases. So monitor respiratory rate, saturation, and chest signs. Oxygen maintain saturation more than 94%. Hypoventilation should be avoided. Risk of aspiration is always high, and even fumes can lead to chemical pneumonitis. Salicylate, make sure that you maintain high minute ventilation. That is also crucial when it comes to managing such cases. When it comes to circulation is another area where we need to be cautious. What do you think is need to be important in circulation? Is about how do you monitor, is about your targets, it's about how do you put IV access, it's about the fluid of choice, it's about vasoactive agents. So monitor patients properly, including pulse, PP, and ECG. You need to make sure targets are maintained. You need to make sure the map is more than 65 mmHg. You need to make sure that capital refill time is less than 2 seconds. And you also should maintain the urine output at 0.5 ml per kg per hour. So it is important, it is crucial that circulation is maintained adequately and effectively. And that is something, another take home thing when it comes to circulation. And hypotension should be managed. Large bore IV cannulas like 14, 16, and 18 cord should be made available. Identify the type of the shock, whether it is distributive shock, whether it's hypovolemic shock, whether it's cardiogenic shock, or it's an obstructive shock. Fluids are NS bar oral crystalloids at 20 ml per kg bolus if required if the patient is in shock. But make sure that you evaluate the patient is not in fluid or alerted state. Inotropic agents are useful. Salicylates, lithiums, make sure your hydration is adequate. Beta calcium channel blockers again will produce bradycardia with hypotension. Careful fluid hydration because it can lead to cardiac failure again. Then arrhythmias, you may think about lignocaine as a supportive drug. So these are crucial when it comes to managing circulation. When it comes to disability, most of these toxicological events can have respiratory depression and also CNS depression. It can have CNS depression or altered mental status. So that means you're playing with something that has affected the brain. In such cases, the issue is you have to identify whether it is purely because of this or there is any bleed or concurrent pathologies that is happening. So evaluate that also simultaneously. Also, any encephalopathy can be septic encephalopathy or metabolic encephalopathy or in hepatic encephalopathy or uremic encephalopathy or any encephalopathies can also produce altered mental status or respiratory or CNS depression. So understand that. So you need to make sure that you monitor the level of awareness, pupils lateralizing sign, and also GRBS. And cocaine, when we used to tell about coma cocktail, it's not much beneficial. That's dextrose, naloxone, and thiamines are not much useful when it comes to managing toxicological managements. Low GCS, always consider early intubation. Seizures, first line management is definitely benzodiazepines. Low dose glucose or hypoglycemia episode, dextrose 25% should be given immediately. And alcoholics, thiamine is definitely going to help you in preventing Wernicke's encephalopathy. So managing this ABCDE is crucial as managing any other case. Now comes to exposure reduction. So any patient which comes to you in the ED, you start stabilizing them from airway, breathing, circulation, disability. Along with that, during that time itself, you get the history. And majority of time, we try to reduce the impact. So that's why I told you are going over airway stabilization. You don't know what you are playing with. Then you avoid depolarizing agent. You just go for non-depolarizing agent and intubate. So you have stabilized. Make sure that the patient is having high respiratory rate. Think about whether the patient is having salicylates. If there is any other features of it, then you maintain high minute ventilation. So you have clues from every point where you're going to manage and stabilize and continue. Exposure reduction or decontamination. We had lots of methods like giving alkalines for acid, acid for alkalines, make sure that there is emit. But these are out of the picture these days. Only thing is, if you want a gastric lavage, you do a gastric lavage with either with water or with charcoal. But the problem is, but the thing is, take home message is you have to do it within 1 hour. The effective times are definitely within 1 hour. So that is important. And when it comes to eye decontamination, copious amount of water, irrigate, 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 irrigate. That is mostly important. Anesthetic eye drops and refresh eye drops will help you out. So unless others you properly irrigate, it can even still be absorbed from your eyes. So that becomes more and more challenging. Then definitely gross decontamination is important in certain cases where the whole body gets decontaminated. You wash them properly. You have to make sure that you wash them thoroughly, and that is very much important. That the problem with that is that you may think that it is not absorbed from the skin. Certain, like especially when it comes to OP, the anticholinergic, the most important thing is that it gets absorbed from the skin. It gets absorbed from the cloth that the patient has, the exposure has happened. Something has fallen on the cloth, it gets absorbed from the skin through the cloth. So dry decontamination, especially removing clothes, then giving us proper wash is important, as important as managing the case. Then GA decontamination, removing from the gut, as I told, gastric lavage is definitely the option. But be careful when it comes to acid, alkaline, fume. So what is a clue? Again, when you open the mouth, you see burns. Definitely something to bother. Lips are having burns. Definitely think carefully before you go for gastric lavage. So when we were talking about how we are going to decontaminate, so we are talking about enhanced elimination, that is urinary alkalization, forced diuresis, hemodialysis by hemoperfusion. So any method in which we can remove it, if that has been absorbed to the blood, that is what we are going to try. And urinary alkalization for forced diuresis with hemoperfusion, each has its role in different types of toxicology manipulation. Especially if I tell, when it comes to paraquat poisoning, even in a tablespoon of paraquat is enough to kill you. So in such cases, hemoperfusion within the first 1 hour, 1.5 hours, plays an important role. That is especially when it comes to charcoal hemoperfusion. So from ED, the most important thing is stabilize, understand what is happening. If you need a hemoperfusion or hemodialysis, push for that. That is another most important thing. So exposure, as I told her, there are drugs which can produce hypothermia. There are drugs which are going to produce hypothermia. So understand that any drugs which is going to produce hypothermia is definitely more challenging than hypothermic drugs. So manage that effectively, and that is important. When it comes to physical examination, as I told, A, B, C, D, E, F. After exposure, when it comes to F, then we have clinical features, repeat vitals, a detailed head-to-toe examination, routine labs, your X-ray abdomen, chest, the ABG, coximetry, lactate. Coximetry definitely play a role here. Then make sure that you do a toxicology screening of blood, urine, and RT aspirate, and then a specific diagnostic if required or if you have, consider that. Then comes to the biggest debate, antidotes. Treat the patient, not the poisoning. That's the biggest take home that I would say. You have to make sure that you treat the poison, but definitely treat the patient first. Certain intoxication antidotes may reduce mortality and morbidity. But if you don't do the proper ABCD, as I told earlier, you're going to kill the patient even before you're going to diagnose what it is. Because antidotes may not be readily available everywhere. So it is important that you understand that and then manage it effectively. So antidotes, the n number of antidotes. I don't know whether every institution have all these lists available with your in your fingertips to give it immediately. So it starts with N-acetylcysteine or acetylcysteines for acetaminophen, to sodium bicarbonate for TCA or cocaine or salicylate. So the list is really, really large. So think about antidotes if required. You need to manage because it's going to help. Certain may help in reducing mortality and morbidity. So, but more importantly, manage the patient to find out what it is. Then, if you feel it is so and so, consider antidote because it should go parallelly. Cardiac arrest, definitely follow ACLS protocol. Your routine ACLS protocol along with early defibrillation and adrenaline. Follow that. But if you need arrhythmic agent, you go for lignocaine. So that is another big take-home message I would say in cardiac arrest. So putting it all together, managing toxicology is definitely interesting, I would say, because it's lots of puzzle. You patient doesn't come to you with a diagnosis. Patient comes to you with n number of clinical manifestations. Patient comes to you with a n number of puzzles. It is your role to solve the puzzle. It is your role to understand what the puzzle is, and their curiosity always is the key. Their having that 360-degree view about the patient is important. Don't go narrow-minded. Don't go saying that, okay, this patient is alcoholic. Okay, fine. Then it is only these toxic. Or if this patient is a drug addict, so these are the toxicological manifestations. No, don't go that. The patient may be alcoholic. The patient may be using opioids. But go with your toxidromal approach, because this point, at that particular point of time, the patient may not have consumed alcohol, the patient may not have used any drugs otherwise. So it may be just another toxicological manifestation with which patient has come to you. So it is important from your point to understand that, evaluate it properly. There comes the role of toxidromal approach. There comes the role of a proper evaluation and management. And that indeed is the key to succeed and to manage. So it is important that you follow the ABCDEFS method, that is airway, breathing, circulation, disability exposure, physical examination, and specific therapies, including antidotes. And these becomes clue, these becomes important. And again, I would say D can also be considered as decontamination. So it will be a breathing, circulation, disability, and decontamination. Then exposure reduction and exposure reduction. Then physical examination and specific therapy. So make sure that you do all this simultaneously and parallelly, because toxicodromal approach with your clinical judgment, with your approach to managing, helps save life, which is most important when it comes to managing any case that comes to ED. So with that, I conclude. I'm open to questions if there is any. And greetings and thank you from Caritas Hospital. And this is my department here. And it's indeed a great privilege to be here, to be part of this program. And definitely a program which I'm sure that will be useful for a lot many students across our country, across various countries, I would say, because it is very hard to have such type of events happening. So it is important that multidimensional treatments and evaluations is important when it comes to managing cases, and that is the clue, or that is the basics about that is the basics about managing any case when it comes to in emergency. So it is about a nutshell, I would say, we all are together for managing poisoning. Poisoning is always about teamwork. Poisoning is about working together as a huge team. It's not a single team, it's a huge team. You may be looking at one point of at one angle, your colleague may be looking at from another angle. So it is important that both the angles are thought about, because ultimately you all are there, or we all are there to save the patient. And saving that patient will have much, much more importance than any other thing that you're going to do. So with that, I conclude. If there is any questions or anything, then I can take it.
Okay, thank you so much, Dr. Ajith. The question will be bring forward to the forum session. Okay. Thank you so much, Dr. Ajith, for the such an insightful and comprehensive presentation on Toxidrome and approach.
Thank you.
Okay.
Thank you.
Sorry. Okay. Thank you so much, Dr. Ajith. Your clear explanations and structured approach to recognizing the toxidromes have given us a solid framework to apply in our practice, especially every second counts in emergency situations. You have highlighted critical aspects of toxidromes that will undoubtedly help us or sharpen our diagnostic and management skills in toxicological emergencies. On behalf of the entire seminar series and all of today's participants, we truly appreciate your time and expertise. We are grateful for your contribution to enhance our understanding and practice in clinical toxicology. Once again, thank you, Dr. Ajith, for your valuable presentation. Thank you so much.
Thank you. It's indeed a great privilege, as I told earlier. Thank you, Mohammed, and the whole team for taking the whole time for organizing it and having me here. So that is again a big opportunity to be here. So I will definitely, it's indeed a great, interesting series that is ongoing. So I'm sure that every resident across the who is listening to it will have a much more informations, which will be definitely useful for patient care. And ultimately, it is about managing the case effectively. So that is about the whole thing. And I'm sure that we all are together for this. And I'm wishing the whole web series the whole very best. And make sure this goes really well. And I'm happy to support at any point of time. I've shared my number also. Feel free to contact. And thank you.
Thank you so much, Dr. Ajith. We have now come to one of the most anticipated parts of our seminar, the forum session. This session will last for 45 minutes, during which we'll dive deeper into the key issues surrounding the clinical toxicology, discuss case-based scenarios, and address questions from our audience. I am joined today by our distinguished speakers, Dr. Ajith Venugopalan, Dr. Taufiq, Dr. Jennifer, and Professor Khaldun. All right, thank you so much to all the speakers. To all the participants, raise your hands, your voices too. This space is ours, for me and you. To ask questions, don't be shy. Together, we reach for the sky. So I will begin by asking each of our speakers a questions to open up the discussion. And after that, we will take questions from the audience. If you have questions, please type it in on the chat board. And I'll do my best to get as many as possible. So let's start with our broad question to all of our panelists. Dr. Jennifer, from your experience, what are the most common challenges you encounter in managing toxicology cases in the emergency department, and how do you address them?
So in our setting, so we are in a urban area, but not similar to Manila. So we live in the northern part of the Philippines. So our cases are mostly pesticide poisoning and pharmaceutical poisoning, as well as snake bite envenomation. So what one of the problems in our setting is the lack of antidotes. In particular, in our case, in our setting, we don't have IV and acetylcysteine. So for paracetamol poisoning, we actually use oral and acetylcysteine. We also have limited supply of antivenom for our snake bites. So we manage our snake envenomations with the combination of antivenom and neostigmine or pyridostigmine. But so far, those are our limitations in our hospital.
Thank you for your response, Dr. Jennifer. Okay, for the Next question for Dr. Ajith, and it's the same question actually. From your experience, Dr. Ajith, what are the most common challenges you encounter in managing toxicology cases in the emergency department, and how do you address them?
Thank you for the question. The most important thing, the most important challenge that any managing any toxicology or let it be bite testing including, is that the time of presentation to the ED. Majority of the time, the patient gets presented to the ED in a delayed manner. And any toxin for that matter, including I would say bites and let it be snake bite or scorpion or things like that, unless the patient is uncomfortable, they don't come to the ED. And most of the time, that crucial period is already lost with us. So that is the biggest challenge that we have. And once the patient is in ED, again, we are beating around lots of things because we don't have what the exact diagnosis is. So that clinical approach management protocols that needs to be followed, finding out what has happened to the patient, because another challenge is a lack of proper history. So a lack of proper history, lack of time of presentation to the patient, to the ED, along with lack of clue about how to proceed forward. These three few things are biggest challenge when it comes to managing toxicology. And another biggest challenge, as I told earlier during my presentation, is everyone is focused more on antidotes. Antidotes is second line, not the first line. So that also should have a perspective when it comes to managing any toxicology for that matter. Moment.
Okay, thank you so much, Dr. Ajith. And for Dr. Taufiq, just now we got a question from Winnie. How long after injection for the urine toxin screen to be positive? Dr. Taufiq?
Okay, thank you for the question. Well, as we know, this test is qualitative test. The test we use for the alcohol detection is qualitative test based on our forensic laboratory protocol in our hospital. A positive result is obtained if there is at least 40 mg% of alcohol present. As for the illicit drug test, it is based on the minimum concentration indicated by the kit in alcohol test kit. But however, the estimation of the time it takes for a positive result to appear cannot be determined with certainty. As it is influenced by several factors, such as the amount of alcohol consumed, the patient's renal clearance, perhaps, and with their hydration status.
Okay. So another question for Dr. Taufiq. From Sofina. Okay. In hospital settings, does urine toxicology need a consent from the patient? And how do you handle a patient that refuses to provide urine sample?
Well, actually, the screen in our hospital setting is not become a standard protocol, especially in trauma patients. So if we want to take a screen, especially in patient trauma, or we suspect this patient come with the intoxication, we must to request informed consent to this patient. But if the patient or the patient's family refuse, the test will not be performed, except in case where there is a request from law enforcement investigator or a court order. Like that. That.
Right. Okay. Thank you, Dr. Taufiq. So there is a question for Dr. Jennifer from Nick Farhan from the audience. If there is anaphylactic reaction upon starting NAC, do we withhold the treatment? Can you explain further measurement if does occur?
For anaphylactic reaction secondary to N-acetylcysteine infusion, we do hold the infusion for at least an hour to allow the blood N-acetylcysteine levels to decrease, and then we resume at a slower infusion rate. So if the anaphylactic reaction happens during the first infusion or the loading dose, then we can prolong the infusion rate to up to 2 hours. Similar with the second bag or the third bag protocol, or the second bag in two bag protocol. If the patient has more serious reactions, we can give diphenhydramine at 1 milligram per kilogram and then also hold the infusion and resume at a lower infusion rate.
All right, thank you, Dr. Jennifer. I hope that answer question from the Nick Farhan. So another question from Nur Shazwan to Dr. Ajith. What are your thoughts about the patient that presented with acute coronary syndrome that preceded with sympathomimetics overdose? So do we treat the SES?
Okay, so multi-departments. Symptom AC is definitely something that you need to treat. So as I told earlier, in your ABC, the C part consists of your vitals, especially pulse and BP. So there, depending on the type of shock, you need to manage the shock. So the shock can be distributive, shock can be obstructive, shock can be hypovolemic, but shock can also be cardiogenic. So if the shock is cardiogenic, it is not about managing with inotropic or vasoactive agents. It is also managing with whatever, whether angiogram or angioplasty or whatever it is that is required to manage that needs to be done parallelly. The thing is, the type of drugs that you use, you need to be careful. And but for an intervention like an angioplasty, it's something that if needed should go for it. But also the only thing that you have to understand is, or only thing that is you have to be careful is that there are possibility of tachycardia cardiomyopathy also. So that can also have ECG changes. So make sure that it is pure vascular, that is the vessel is involved, then probably a simple angiogram will help you with that. If it is so, then you need to manage without any doubt. Thank you for that question anyway. So,
All right, thank you so much, Dr. Ajit. I hope that answered the question from the Dr. Nur Shazwan. So we move on to Dr. Taufiq. Okay, in the situation where patient was intubated, do we need to consider pre-medication given during RSI for patient suspected intoxication in urine drug test? It's a question from Nick Farhan. Okay, to Dr. Taufiq.
Okay, thank you for the question. Actually, all the sample for this patient, we collect the screen from the blood and urine, especially before the patient do the give a drug, like if when to intubated, we giving the pre-medication, we don't we don't take the blood sample or urine sample from to the to do the tox screening. So all the sample if the in the this were collected is not clearly clear from the drug induced from this patient. Clearly, my voice is clearly my
Okay, thank you, Dr. Taufiq. So, there's another question actually, to any of the speakers from the audience, Mark Anthony. Have you utilized the use of lipid emulsion as an antidote for hydrophobic substances or medications? It's an open question to any of the speakers. The question from the audience, Mark Anthony.
Yeah, lipid emulsion definitely has a role in managing certain types of toxicological management, especially when it comes to local anesthetic toxicity and things like that. But choosing it rightly, again, as I told, choosing it rightly is the most important thing. And it helps in managing most of the syndromes before it goes to a cardiac failure and things like that. So managing it, picking the correct point is definitely useful, and we have actually used it for especially for cases like local anesthetic toxicities.
All right, thank you so much, Dr. Ajith. So, okay, continue to the Dr. Ajith. Why lunakin was preferred for the anti-arrhythmic? It's a question from Nick Farhan.
Yeah, always we have a confusion whether lignocaine or amiodarone. Both are good anti-arrhythmic agents. Both are broad spectrum, but when it comes to lignocaine, it's a class 1B anti-arrhythmic agent. The thing is, lignocaine, whether it needs to be preferred over amiodarone, as I told you, almost have both plays somewhat same role or somewhat same platform. But few studies have shown a better neurological outcome because with lignocaine, better anti-arrhythmic management when it comes to toxicological with lignocaine, and also better discharge rate with lignocaine. So that multiple few studies where have given a bit upper hand for lignocaine, especially when it comes to managing toxicology as a pure toxicology, because there are this lignocaine also have permeability in neurons and things like that. So majority of the toxicology has that neuronal management requirements. So probably because of all this, lignocaine has a bit slightly higher upper hand when it comes to amiodarone.
I hope that answered the questions. For Dr. Jennifer, there is a question. How long will we define acute ingestion? Is ingestion at one time will be managed same as ingestion over the 24 hours? I repeat my question. How long will we define as acute ingestion? Is ingestion at one time will be managed same as ingestion over the 24 hours?
Okay, thank you, doctor. So let me just clarify the question. The question is, how long do we define acute ingestion? Is that right?
Yes.
So, based on the US and Canada consensus statement, acute ingestion is any ingestion occurring less than 24 hours. And beyond that, that would be considered as supratherapeutic ingestion.
All right. Thank you so much, Dr. Jennifer. So, we move on to our next question, to Dr. Ajith. Can Toxidrome presentation be affected in special population with different physiology? For example, pediatrics, elderly, or pregnant lady? Does it affected because of the different physiology in different special population? Thank you, Dr. Ajith.
Yeah, thank you for that question. The thing is, depending on the age group, I would say, when it comes to elderly, then majority of the physiological hindrances are already in place. Like the patient would have already have a cardiac background, the way patient would have a renal background, there may be a cardiac failure in background, there can be a CKD in the background. So because of those limitations that we have, even a smaller dose can have a bad effect. So that is one biggest disadvantage when it comes to an elderly. When it comes to a pediatric population, the issue is the volume of distribution varies, because the small quantity of poison when it comes to an adult, and that same small quantity when it comes to pediatric, the volume of distribution is definitely going to be high. So that is the biggest challenge when it comes to pediatric population. But when it comes to like snake bite and things like that, the venom that is injected by the snake is same for adult and pediatric. It doesn't change. That's why the anti venom that needs to be given should be given the same dose. But the problem is it gets distributed very fast, and it gets affected. Every part of the organ gets affected much more faster. So, and like adult, there may not be a strong blood-brain barrier, or barriers are may not be that strong when it comes to adult, especially the pulmonary capillary membrane strength, the blood-brain barrier strength. That may be just in the developing phase. So that is a hindrance when it comes to pediatric. When it comes to pregnant lady, the biggest challenge is whether the drug can cross the placental barrier. Certain can cross, certain cannot cross. If certain can cross, it definitely is going to have effect on the embryo also, or the developing baby also. So that is where it gets affected when it comes to a pregnant lady. So it is very hard to say that in just one statement that it is definitely have effect when it comes to adult versus pediatric versus geriatric versus obstetric. But I would say that it needs to be taken cautiously in each case separately, and then managed separately. That's how it needs to be. But definitely there can have variations of presentations and complications when it comes to different age groups. Thank you.
Thank you, Dr. Ajith. There's open questions to all our panelists. A 40-year-old male found unconscious in his room. 40-year-old male found unconscious in his room. Brought to the emergency department, agitated, combative. BP was 152 over 98, 152 over 98. Heart rate 142, temperature 37.2, and paramedics saw open blister, packs of approximately 200 tabs, 25 mg amitriptyline, and a bottle of whiskey. So, what are the immediate steps you take to stabilize the patient?
So can I go start with it?
All right, Dr. Ajith, can proceed.
So basically, it is important that the patient's vitals is as of now stable, from what I understood. Patient's sensory needs to be verified. The patient, whether you need to stabilize him ABC, is something that you have definitely think about. But when it comes to amitriptyline as such, when it comes to antidepressants as such, only thing that you have to be the major cautious should be whether there is a CNS depression, there is a respiratory depression, whether there is a hypertension. So these three things are CNS, VVS, and respiratory. These three things are something that you need to be careful. So securing IV cannula early, sending the tox screens early, and also most importantly stabilizing ABC early is going to be helping you manage that case effectively.
So, the second question, will there be any drugs that are contraindicated in this situation? Will there be any drugs that are contraindicated in this situation?
Drugs contraindicated. It depends on the situation, I would say. It is a very broad statement when we say there are drugs that is contraindicated in amitriptyline toxicity. But I would say it depends on the situation that we have, any other blood parameters that the patient is having, whether we need to consider any other specific drugs to be given. I won't say in broad sense, there is nothing that needs to be contraindicated. Only thing is, patient, because of the patient is having a possibility of hypotension, the possibility of serious depression. BP of 160, don't start managing that BP of 160 immediately. That's the only thing that I would say. Just wait and watch and manage it simultaneously.
All right, thank you so much, Dr. Ajith. Is there any more questions from the audience? You can put it in the Q&A section box. Okay, if we are waiting for any more questions from the audience to enlighten more on our topics. So we get back to the Dr. Jennifer. For Dr. Jennifer, what do you think the key developments in clinical toxicology should emergency practitioners be aware of in the coming years? And how do you see the field evolving, the clinical toxicology? Thank you, Doctor.
So I think in one of the things that we should be looking forward to is the availability of more tox screens across all institutions, because in the Philippines this is one of the challenges that we encounter, aside from um, availability of antidotes, no? And also we should expect more of local researches, especially on common poison toxicants in our country. That would be paracetamol, as well as um, methamphetamine. So, because in paracetamol poisoning, there's still a lack of researchers, too little researches on randomized controlled trials, especially on management, on how long do we give and acetylcysteine. Do we follow the same protocols used in Western countries, or is it possible that we modify the protocols on acetylcysteine infusion based on our genetic materials, especially for Asians and Asians and Southeast Asians, because there are studies that um, indicate that among Southeast Asians, hepatotoxicity related to paracetamol poisoning is relatively low. So, I think that that should be one of the researches that will be done in the future. Thank you, Doc.
Hello, thank you, Dr. Jennifer. So we move next to our. Okay, there is one more question from Nick Farhan from the audience. Is there any ventilation strategy in case of intoxication? Is there any ventilation strategy in case of intoxication? It's open to all the panelists.
Should I take it?
Okay. All right, sure, Doctor. Sure, Dr. Ajith.
Ventilation strategies is basically better use a non-depolarizing drug to intubate. Make sure that you maintain a proper minute ventilation right from the beginning. Make sure you don't go for a low minute ventilation unless otherwise you are thinking about ARDS. And always have the clue that the patient may have an ARDS in the background. So then you have to think about ARDS ventilation also in background. But otherwise, what was the physiological respiratory rate? Try maintaining that during the initial time. Then start tapering it depending on what diagnosis that you have, especially if there is an issue of salicylate in the picture. Otherwise, maintain a proper minute ventilation. That will be fairly good enough.
Okay, thank you so much, Dr. Ajith. So maybe we're almost out of time, but before we close, I would like to ask questions to Dr. Taufiq. Same question with to Dr. Same question. What the key developments in clinical toxicology should emergency practitioners be aware of in the coming years, and how do you see the field is evolving? Dr. Taufiq.
Okay, thank you for the question. Thank you for the question. Actually, the clinical toxicologist is the more important profession from in the our profession in our medical profession. But actually, in our country, is the this profession. This profession is still lack of the still need more effort. Yeah, if you want uh, to do the to be a clinical toxicologist, because as we know is our limitation is too much, and not all the our hospital support the equipment and the facility or in and the tox screen especially. So if we want to win, if we want to do more if you want to know about the clinical toxicities, and could be to be, could be to be more enthusiastic with other people, so we must to struggle and and need for the more research and more experience to like this event especially. So, and if we lot of we if we uh, if we do this like this season and every years, perhaps all the stakeholder can could be could be interest and know if there are a lot of the toxicology case in our environmental. So I think it could be make a differentiated uh, intervention in our policy, especially in our government. So I think the toxicologist experience would be more. I think the more case toxicology case would be no in other people. I think it like all about this clinical toxicities. That's all that Muhammad Ansari.
Thank you, Dr. Taufiq. So, for Dr. Ajith, is there any final words you want to tell the participants, or any advice, any take-home message for the all the participants?
the the biggest thing that I need to tell everyone is that we are toxicological issues are increasing day by day. It is important that we have that clue, or we have that open mindedness to understand that each case may not be a straightaway case. Even patient with encephalopathy that comes to you, patient with other manifestations that comes to you, if you don't have a clue, or if you don't are not able to solve it properly, think about toxicology, because you may miss it because there is no history proper. and even the patient may not be aware about it. So that is a situation that we are going in with it. Your clinical toxicology is important. Using of all your analytic toxicology is also important. Making sure that you utilize your lab resources effectively is important. And ultimately, it is about working together as a team along with your critical care unit, the medicine unit, because everyone plays a key role. And maybe one point from somewhere will help us to manage the case effectively. So that is the most important thing. And I would say again a big thank you to the whole unit for organizing it, especially Professor Kalbin and also Dr. Muhammad for inviting and having me here. Thanks a lot.
Right, thank you, Dr. Ajith. Dr. Jennifer, if you want to add any more for this webinar to close
Thank
our
you,
webinar
Doc.
today.
Thank you, Doctor, for inviting me. I think for toxicology, it's always emerging, so we should always be abreast with the new treatment guidelines and make sure that this new knowledge will be shared with our toxicology team within our hospital or another hospital so that we can improve our patient care more. Thank you.
All right, thank you so much, Dr. Jennifer. So, Dr. Taufiq, we keep Dr. Taufiq for the closing remarks after this. Okay. Remark and ends to our forum session today. So, thank you to all of our panelists for their expertise and thoughtful answers. It's been an incredibly enriching discussions, and we are grateful for the time and knowledge shared today. We have covered a wide range of topics in this forum session, but there's always more to learn. If anyone in the audience has additional questions, please feel free to reach out after the seminar or follow up with us through the provided contact information. With that, we conclude today's forum. Thank you once again to our speakers and all of you who participate. Now, we are moving on to our final session of the day, which is the Kahoot quiz. This is your chance to test your knowledge on clinical toxicology and have some fun while doing it. Not only will you be able to see how much you have learned, but there's also a special prize for the winner of the quiz. So here's how it works. Okay, we'll be sharing the Kahoot game pin in just a moment. You can join the game by going to Kahoot using the Kahoot app on your phone or browser. Once you're there, simply enter the game pin and your name. The quiz will be fast-paced, so be ready to think quickly. For the winner of the Kahoot, please make sure to contact the organizing community to claim your prize, and good luck to everyone. Thank you so much to all our panelists today. Thank you so much.
Thank you.
Thank you. Thanks a lot.
Right,
Thank you.
We move to last questions. Okay. Wow, what an exciting finish to today's seminar. A huge congratulations to our Kahoot winner, ToxPH. Please screenshot and then don't forget to contact the organizing committee to claim your well-deserved prize. Okay, screenshot your screen and then contact the organizing committee to claim your prize. Thank you. So I would like to invite Dr. Taufiq to give closing remarks for today webinar. Dr. Taufiq, please share your screen and give the closing remarks for today webinar. Thank you, Dr. Taufiq.
Okay, thank you, Dr. Zar. Okay, Alhamdulillah, I have finally reached the end of the emergency medicine seminar series event in the first week. Hopefully, the material provided by the speaker can benefit all of us. And then, thank you for your listening. All those we have shared be beneficial for all of us. And then, thank you to the moderator, Dr. Muhammad Azhari. Thank you for all the speaker and the entire committee for overseeing this event to completion. And then finally, we will see you in the third week in October in part of the emergency medicine seminar series event with the title clinical toxicology. Thank you for all.
Okay, thank you so much, Dr. Taufiq. I want to take a moment to thank our amazing speakers today for sharing their invaluable expertise in clinical toxicology. You have given us all new tools and knowledge that we can take back to our daily practice, making a real impact on patient care. To all of you who participated and asked questions, you have made today's session even more engaging and dynamic. This is what it's all about, learning, growing, and supporting each other in the field of emergency medicine. Don't worry, this is just the beginning. We'll be back with more stimulating discussion and knowledge sharing on the October 17th. So make sure to mark your calendars. The next webinar is going to be even bigger and better. And we can't wait to have you join us. Okay, the QR code will be shared after this. Until then, stay in. QR code already shared. Please scan your QR code to get your e-certificate and CPD points. Okay, until then, stay inspired, stay passionate, and let's keep pushing the boundaries of what we can achieve in emergency medicine. Thank you for your time and energy today. You are the heartbeat of this community. So take care and we'll see you soon. Thank you so much, everyone.